our guest speaker, Dr. Katherine Bianco. Dr. Bianco is an MFM and genetics specialist. She is originally from Caracas, Venezuela, where she graduated from medical school at the Universidad Central de Venezuela. She subsequently completed a postdoctorate studies at the NIH under Dr. Roberto Romero. There she focused her research on the maternal-fetal interface and its relations to preterm labor. After this, she completed her OBGYN residency at Yale University, followed by a combined MFM genetics fellowship at UCSF/Stanford. She was the recipient of an NICHD Reproductive Science Development Award and a K08 Physician Scientist Award at the UCSF Regenerative Medicine Institute, a role that she held for 8 years as she pursued her research interest in the genetics of birth defects, especially congenital heart defects. Since joining the MFM-OB division here at Stanford, her research activity has been in the translational sciences realm, while also developing further clinical expertise in maternal congenital heart disorders and adverse perinatal outcomes. So please join me in welcoming Dr. Bianco as she presents the Stanford Maternal Cardiac Research Program, Getting to the Heart of Maternal Morbidity and Mortality.
So thank you so much. Anna, if you don't mind, I can just share my slides. That would be easier.
Go ahead.
Thank you so much for that kind introduction, Dr. Alcedid. It's my pleasure and super honored to be asked to come and present our, I would say, work in progress with the Stanford Maternal Cardiac Research Program. We like to think that we are studying the heart of the maternal mortality and morbidity. My idea today is to just give you a little sense at how the program is doing, what we have learned, what have we been able to put forward, and have a little bit of report where are we going from here. So without any further ado, I want to take you. Okay. So I just want to start emphasizing with this very important thought, and I tell everybody about this. I do believe strongly that it takes a village to be able to support such a complex high-risk population in a medical center. So it would be naive to think that nowadays we can take care of a mother that perhaps has a corrected or uncorrected congenital heart defect, or a baby that is carrying that defect as well alone. So I'm extremely lucky that all the progress and success of this program clinically, educationally, and from the research scope has been going forward due to the fact that it's a collective effort from everybody. So it does take a village, and I'm very grateful for that. So if we look at, just as a quick slide, what do we know? We know that thanks to the MQCC cleared publishing an investigation and be the pioneer in not only the United States, but also, I would say globally, we have been able to identify that in countries like us, the increased risk for maternal mortality is led by cardiovascular disease. A lot of these are due to cardiomyopathies and other cardiac disorders, but congenital heart defects are right there too. So we have been fortunate to have these strong data coming from our own grown collaborations here in the California state, but also this had sharp, a lot of, I would say, enthusiasm for other organizations to look into. So for instance, the American College of Obstetrics and Gynecologists joined forces with the American Heart Association, and they decided to put this presidential task force in pregnancy and heart disease. And this is a phenomenal document. Whoever had the opportunity to read it should go ahead and read it. It's very lengthy, but very concise. And pretty much what it calls is for have a collective effort to take care of this mother and take care of before the pregnancy, during the pregnancy, and after the pregnancy, which is very important as well. Many other centers, major medical centers in the country are following this recommendation. So we're not alone. There are different centers. For instance, there's this very interesting paper that was just recently published out of Carprec in Canada that had helped us to sort of like come up with risk stratifications, how to select and treat this patient depending on their different criteria. And I will show you a little bit of that. And also we have multidisciplinary teams being published in different aspects of the country, in the Northeast and Midwest and us. So it does take the effort of maternal fetal medicine obstetrical team. It does take the effort of cardiology with all the RAMs. So we're talking about all kind of cardiology specialists and general cardiology. And we are super fortunate to not only have anesthesia, but to have dedicated anesthesia as obstetrical anesthesia and as cardiac anesthesia. So when we conduct our multidisciplinary clinical monthly team meetings, this is a superb team to get together to guarantee the best care of these patients. So just in the same clinical consideration recommendation from ECHO, the American Heart Association and others, we better to understand the patient pathology and the patient condition before the patient gets pregnant. And that's one of the main goals of my research projects with the cardiac heart team, is to try to understand how we can get to these patients before they get pregnant, to optimize their care and then safely take care during their pregnancy. So a study came out of over 1 million people, women who were a study in Canada. And what it was interesting is these patients had kids or fetus or infants that were diagnosed with congenital heart defect. And what it was, the silver lining of this, I would say, prospective long-term follow-up study was that these patients had an increased risk to themselves have congenital heart defect. So now we are thinking the fetus as telling us to take care of the mother. So I like to have also that sort of like during our fetal program, we take care of a tremendous amount of patients with carrying congenital heart defect fetus. So it's also something that you also want to keep an eye on it. If the lesion of the baby is a lesion that has been related highly with chromosome abnormalities or genetic condition, this perhaps can be an indication for maternal echo. This will be more conotruncal defects. I want to put a plug there for Dr. Alsager, the center director, and invited me to be here, be part of this amazing opportunity in the Dunlevie maternal fetal medicine. We were super lucky to get this support, for very generous support. I want to quote our dean, where I was describing the opportunity to have this $30 million to further develop a world-class maternal fetal medicine program in the School of Medicine. We know that this hospital treats very complex fetal disorders. We just learned that we're going to have the opportunity to continue foster our fetal surgery project program, which Dr. Jared has been doing very successful. But we also know there are other things that we have to take care. That is our expectant mothers. So there's potential for more investigation of patients with heart disease, cancer, epilepsy, diabetes, and other problems. So I just want to put the plug there. And I also wanted to make sure that Dr. Alsager knows right in front of this, that we're very grateful that we're working together. So with other, without further ado, I wanted to get to this group, but the sort of like the description of who we are and how we work. So we follow this maternal heart program, as I was telling you, as a multidisciplinary approach. And that means that we are in both hospitals. We're in the children's hospital and in the adult hospital. We're very fortunate to be able to not only have maternal fetal medicine expertise and an obstetric specialist, but we also have cardiologists, physiologists, pulmonary hypertension, primary specialists, heart failure, cardiogenetics, hypertrophic cardiomyopathy, arthropathies, the Marfan Center. We have OB and cardiac anesthesia. We benefit from CT surgery and neonatologists and genetics. And I would say this is not just based on doctors. We also have absolutely amazing ancillary support with our nurses and coordinators and patient navigators. So it's the secret of our success. It's the team that we have. So with a comprehensive approach and a team effort, many successful pregnancies have been achieved. And I want to share some of that data. So where are we these days? We actually have a milestone of 10 years since this program was initiated. I can't take all the credit because I just parachuted 7 years ago, but as you can see, this effort and this systematic approach has led it to have so far 343 pregnancy of 291 unique patients. Just a little bit of race distribution to the left, and what type of maternal cardiac disease we are seeing. As a common denominator, it tends to be 50-50, half and half, congenital versus acquired. Granted, acquired, and I will show you the list of different disease, it tends to be a lot of arrhythmias, complications, but also ischemic events and SCAT. So here the list of different patient diagnoses that we take care. As I was telling, the bulk of them are arrhythmia, but we also have other very scary in our list here, like aortic coarctations, aneurysma. We have pulmonary hypertensions. So highly critical patients that we are trying to help them through the process of their pregnancy and delivery safely. We have patients with valvulopathies. We have patients with uncorrected congenital heart defects, or patients with secondary cardiac affections that could be by hypertension disorders and other things. When we look at it roughly, this is just roughly numbers I wanted to bring it to your attention. We have a sizable amount of complications that not complication, but adverse perinatal outcomes that you would expect. So we definitely see an increase of preeclampsia, and some of them very well represented by severe futures. We have a component of gestational diabetes and others. When we look at the time of babies are being born, we definitely see an increase over baseline for preterm birth, but you have to granted also see how many of these are clinically indicated and not really related to preterm labor itself. One of the things I really like to see is, like, for our model of delivery, we're almost half and half. So it hasn't quite increased as bad the need to have a C-section. We support labor, and a lot of our patients sometimes will work with the team with anesthesia, coaching the patient, doing what I would call a second stage assistant, or even labor down. So really bringing the vertex down low, so mom doesn't have to push for too long and doesn't have to bounce out for so long. We have quite a bit of patients that need to be in telemetry, and quite a bit of patients that sometimes require to go to the intensive care unit. I want to put a plug here that Dr. Al-Sajed has been our tireless fighter to guarantee 24/7 telemetry in our patient, in our labor and delivery unit and postpartum, which really makes a difference from maternal, I would say, mental health and bonding with her baby. I will show you some data so you can already understand how these patients that were either born with this condition or are living with a condition, how going through the process of being a mom and delivering can be so stressful and create mental health disturbance. So having the possibility of not separating the mother from the baby is key. So I really appreciated the support of Dr. Al-Sajed to continue guarantees 24/7 telemetry. So just to give you a little piece and bits of things that we've been doing. And I also want to stop here and recognize that this is a clinical program, okay? And we all work together, but we also are part of an academic institution. So we have been taking advantage of that, looking at educational opportunity and research projects. So many medical students and residents and fellows and even junior faculty have benefited from participated in this program with regard to research questions, which I'm very excited because that's the way to advance the field. So one of our past chief resident, now RAI fellow at UCSF, was interested to understand really what our program was showing, and if we really were making a difference with this multidisciplinary approach. Granted, we have a very small cohort, very unique, very high risk population, but a small cohort. So she decided to look at our patient population. As you see here, we keep a data intake to the left. This is what we have constant, I would say systematic every month, and this data gets entered into a red cap. The patients get referred from different places, either to maternal fetal medicine or from cardiologists to us, or from OB to us, or from adult congenital to us, and vice versa. We look at the AMR and we look at different parameters from the time of pregnancy to the delivery and mode of contraception. So what we learned was like, well, what if we back in the day when Alicia was here, we said, well, we had almost 10 years. So what if we divide this into epoch and say early years versus later years, because we feel like we have been becoming more like an expert center for this type of patients, which have allowed to increase our better understanding and change our approaches, if you will. In order to get a little more sense that where we've been objective of this, we decided to look at the data based in the World Health Organization certification to have some kind of criteria of severity. So if you look here to the right, we were looking at to see the tendency of planned C-section. These are planned scheduled C-section. We decide these in our multidisciplinary plans, okay? This is not intrapartum C-section. And also where this C-section takes over, you will see that by the World Health criteria, before and after, if you will, red being before, gray being after. We did some modification, but some of them I would say is more based on, if we fear that it is based on like our knowledge and knowing which critical patient will benefit to have a scheduled C-section, and it will benefit not only having a scheduled C-section, but have it in a main OR with cardiac anesthesia and up to 30 to 40 personal support delivery. So one of the things that we actually kind of liked, I put it here, from more generalized approach to patient center, was like these patients get individual discussion by many experts and have discussed and tend to be discussed monthly. So that's how it gives us a little bit more like patient center approach. So we went from generalized to patient center approach, from more aggressive to less aggressive, or less invasive, if you will, when indicated. So if you look at this graphics here, I want to point it out that when it's necessary, we will be as invasive as putting an A-line in this patient. When it's necessary, we will have intrapartum telemetry and postpartum telemetry. But we also have a tendency to have change as we have been learning how to reassure and who needs it and who doesn't need it. So more like a patient-centered approach. With regard to the other part of the research, I would say branch that we want to think about this patient, Dr. Miller used to be our resident, now our MFM fellow and future colleague, had the thought that, well, what if we start looking how we can use contraception to prevent this pregnancy, for instance, so patients can have better optimization and then they can plan the pregnancy with all of us being there. So she decided to look at what about our program, what our program showing. If it having this multidisciplinary approach and discussion, does it help with uptake contraception? And she looked at particular LARC contraception. So I'm not going to take the time to discuss all this. I just want to give you a little blur. So every different things that we had studied, and we did find improvement in uptake contraceptions at 8 weeks postpartum, and this was more based in LARC and tier 3. So little by little, we've been given to the field information of very clever cases that we had successfully delivered and outcomes here at Stanford by this multidisciplinary approach. So I want to put the plug there to show you how we collaborate with CT surgery, we collaborate with cardiology. This was one of my patients that the first time that showed up into my clinic, we were all like, okay, this is impossible, you can't be pregnant. She was obese, she had diabetes, she had chronic hypertension, she was short, and she was found to have bicuspid aortic valve. And she also had an ascending aortic aneurysm and happened to carry a twin pregnancy. Well, after many, many discussions and patient refusing to actually interrupt the pregnancy, and then plan it ahead in the future. We supported as much we could. I'm glad to report that she did well. We planned her C-section, we moved her, we have the Stanford is so marvelous place to work that we have local housing. We brought her from the community here. She required a lot of intervention. But one of the best part of this was the patient 6 months after delivery got her valve replaced and she's been doing well. We have another case that we also was very interesting, Dr. Alsager patient. We also described that by one of our residents, incoming MFM fellow, looking at this recurrent atrial myxoma in pregnancy and how she was treated medically and how she was able to have her pregnancy and delivery with uncomplicated, and then went ahead and got her postpartum reception. Changing a little bit gears here, not only about the body and the heart of the mother, but thinking about what else are there that we can use to optimize for our patient in the program. So looking at social determinants of health. This is based on Stanford data. We published in the American Heart Association looking at this, and we did see some difference in demographic. The majority of the difference we're seeing in intrapartum patients, where lower income interpartum patients would have increased outcomes of preeclampsia, preterm labor, and more hospitalization. Data limited to only our zip codes, Northern California. So we are taking this to the next level. One more plug for one of our incoming MFM fellow, hopefully in the future, Sarah Miller. She thought to look at, well, what it means to have this multidisciplinary team, what it means for patients after they deliver. Can we look at it? So she surveyed using RECAP the patients, and she got about over 100 responses. And what we learned is that patients from this program with this multidisciplinary care were more dear to come back to see their PCC or cardiology after delivery. One thing that really caught our attention was that 25% state that they had depression or anxiety. That prompted Dr. Panelli to really start hammer the idea that we should start integrating mental health in this patient population. And I will take you through different projects that we are now developing with very successful. We just learned today from the maternal heart team, trainees, Elisa Padron and Lisa Valdez got their Med Scholar approved. And Norma Jimenez is our 4th year. She already have her Med Scholar approved. So take it the floor. I can move the slides for you guys.
Thank you so much for the introduction. So I'll get started with my project. And if we could get into the next slide, please. And again, I've been working with Dr. Bianco and the MFM team for almost a year now, and I've been very happy with the team. And I'm excited to tell you a little bit about my own project that's been funded by Med Scholars that has been getting a lot of mentorship as well from Dr. Panelli. And this project is on the effects of adverse childhood experiences on pregnancy outcomes in women with cardiac disease. Next slide, please. Sorry, next slide.
Yeah. Okay.
So yeah, ACEs or adverse childhood experiences are these traumatic events that in the realms of abuse, neglect, and household dysfunction that have been shown to lead or be associated with higher risk of diseases such as hypertension, stroke, even higher risk of premature death. And so my objective with this project is to characterize the rate of ACEs in pregnant patients with cardiovascular disease, and also describe any associations that we see between ACEs and perinatal outcomes. Since this is a very high risk population already, we want to make sure that we can screen for any people within this group that might need extra help. So I do hypothesize that patients with an increased number of ACEs have an associated increased risk of adverse pregnancy outcomes. Next slide, please. And so the study design is pretty simple. We've sent the ACEs study questionnaire, which is a 10-question quiz on the 10 different categories of adverse childhood experiences. And then we're looking at the perinatal outcomes from these patients, including preterm delivery, preeclampsia, gestational diabetes, mode of delivery, etc. And also looking at pain-related outcomes, including opiates prescribed on discharge. Next slide, please. And so I'm really excited to share some very preliminary results from the few people that have answered the survey so far. So so far we have 58 patients respond. So fortunately for our group here, the majority, about 52%, have not experienced any childhood adverse experiences. And when we look at the demographic distribution within this group, we see that it's a very similar to the general cardiac database cohort, where it's mostly Caucasian, non-Hispanic, and uses private insurance. But then we start to see some differences when we separate the group that has experienced ACEs from the group that has not experienced ACEs. In particular, things like BMI, chronic hypertension, and depression and anxiety have been shown. We see a trend in increased rates in these diseases, which is similar to what we know from the literature with ACEs. Next slide, please. And so when looking specifically at the perinatal outcomes, again, this is a very preliminary data, but looking at things like gestational diabetes, out of the 7 patients that had gestational diabetes, 5 reported some sort of adverse childhood experience. And in the similar vein, we saw increased a number of patients with fetal growth restriction. But on the other hand, with things with preterm delivery and preeclampsia, which has been associated with increased number of ACEs have been associated with increased risk of these 2 positions, we are actually seeing the opposite thus far. So we're learning more and more as we continue to get more patients involved with this study. But something that popped out and that I'm very interested in learning more about is that about 5 out of 6 of our patients that had operative vaginal deliveries reported some sort of adverse childhood experience in their childhood. And then when we look at pain-related outcomes, specifically here, I'm looking at milligrams of morphine equivalent prescribed on discharge as a way of seeing how much opiate was required by these patients. So we know with vaginal deliveries, most patients didn't require opiates, but looking specifically at cesarean deliveries, I noticed that patients that had experienced ACEs had almost twice as much of a requirement for opiates on discharge, which I thought was a very interesting finding, and I hope will carry through as we continue to incorporate more patients. So stay tuned to find out more about how ACEs might affect the perinatal outcomes in our very special population. And with that, I'd like to thank you for this time for me to talk, and I'll pass the baton right to Elisa.
Thank you, Norma. My name is Elisa. I'm a first-year medical student at the Stanford School of Medicine. I've been very fortunate to be working with the maternal heart team under the supervision of Dr. Bianco since October 2021. So with the help of Dr. Bianco, I've been creating a Med Scholars project for the past year, and I'm so glad to say it got approved. It took a lot of work, so super excited. My project is understanding the barriers, preferences, and experiences of patients with congenital heart disease in the 4th trimester. So the 4th trimester is another term for like the postpartum period or the time after delivery, which can be up to a year for some patients. This project idea came from seeing patients with a congenital heart disease go from a highly intensive medical care model from a cardiologist, OB, and anesthesiologist to a uniform 1 postpartum OB appointment. Patients are balancing their own recovery while also trying to take care for their newborn. I'll be using this framework on the right of the slide so we can look at how to change the 4th trimester into something that can be more beneficial to patients. Here on the outside, we see the patient's expectations, experiences, and reflections they had during their delivery and the 4th trimester. Other factors in the inner circle are barriers, social supports, and parental self-efficacy. These all play a factor in how patients want their postpartum care to look like, and also whether or not they want to attend their appointments. So with all these factors in play, I'm hypothesizing that this decrease in medical care these patients experience during this transition could be due to barriers that they could be facing, and also their new motherhood responsibilities and the regimented postpartum guidelines that might not help all patients. The next slide, please. So my methods are, I will be sending a follow-up survey in English and Spanish to this database that we have of patients. Using this data and already chart extracted data, I will be recruiting participants for structured interviews also to gather more information about their experiences. Here are the number of people we have of congenital heart disease. So out of the 291 patients, we have 140 congenital heart disease patients. And then out of these patients, I will then be recruiting 15 Spanish-speaking patients and also 15 English-speaking patients to do more in-depth interviews. And the next slide, please. So the primary outcome is the attendance rates of the OBGYN and also the cardiologist, but also looking at other variables that might impact these attendance rates. And currently I am working on my quantitative and qualitative survey instruments, which are being tested by other researchers. And the next steps would be to submit those to IRB for approval and then emailing REDCap surveys and recruiting these 30 patients to do interviews. So thank you for your time, and I will pass it off to the wonderful Lysandra.
Thanks, Elisa. Hi, everybody. My name is Lysandra Vélez, and I'm also a first-year medical student here at the Stanford School of Medicine. I was very lucky to start working with Dr. Bianco on the maternal fetal medicine team when I became a scholar at the Leadership and Health Disparities Program, LHDP, last summer. And I've been working in different projects with the team since June 2021. But today I am very excited to share my own project who got funded by Med Scholars like half an hour ago. So, and we're focusing on influence of social determinants of health in postpartum contraception, uptake, and retention in women with cardiovascular disease. So as we know, pregnancies modify women's cardiovascular systems to allow for fetal development and proper placentation. These adaptive changes can lead to decompensation in women with high-risk pregnancies, including those with cardiovascular disease. Maternal cardiac affections are the leading cause of morbidity and mortality in the United States. And for these reasons, it is imperative that women with cardiovascular disease are counseled about contraception, including postpartum contraception, since short birth interval and unplanned pregnancies can lead to maternal and neonatal mortality. Postpartum women also have one of the greatest unmet need for family planning, and more often than not, they do not receive the services needed to ensure longer birth intervals and reduce unintended pregnancies. The postpartum period itself is an excellent window of opportunity for women to initiate highly effective contraception because they have access to healthcare and insurance coverage. So prenatal and postpartum contraception counseling are essential, but not every patient has equal access to contraception services. For these reasons, in this pilot research study, we will be addressing the influence of social determinants of health in postpartum contraception uptake in women with cardiovascular disease through chart review and a follow-up survey with the objective of understanding possible barriers to postpartum contraception in women with cardiovascular disease. And we hypothesize that women of lower socioeconomic status, lower education level, and from minority races and ethnicities face more barriers that make them less likely to uptake or continue with their contraceptive plan postpartum. Next, please. So for our study design, I'm using the same REDCap database as Norma and Elisa. And we have pregnancies complicated with cardiovascular disorders who delivered at Stanford between 2012 and 2022. And they will be surveyed 1 year postpartum about their current contraceptive methods, with the primary outcome of finding out what are the rates of those contraceptive uptake and retention. For my progress, I am very excited to share that I just started sending out surveys on May 2nd, so only 10 days ago, 258 surveys have been out of those, 244 in English and 14 of those are in Spanish. And out of this, I got a amazing 41 responses in just 10 days, out of those 39 in English and 2 in Spanish. So I'm very excited to eventually come back to this audience and maybe share some more of my progress. But for right now, this is all I have. And I really appreciate you taking the time to listen to me today. And I look forward to answer any questions you might have. Without further ado, I will pass it back to Dr. Bianco. Thank you so much.
Excellent. This was amazing. Thank you so much for sharing these very preliminary results, but very exciting. So we're studying the heart of the patient both ways, from the biological point of view, but also from the soul point of view. So we definitely will have amazing data to present maybe in a year from now. So I know in the interest of time, I had a few other things I wanted to share with you, just exciting things. I want to let you know that part of the maternal heart program is collaborating with the Metabolic Center. We are, already having some track records with the Metabolic Center, looking at abnormalities in the maternal fetal interface, looking at a cohort of patients that have placenta abnormality, a cohort of patients that have preeclampsia and fetal growth restriction with Dr. Wynn and Dr. Lyle. We are doing some telemeter studies in these cardiac patients as well. And we are partnering with a very exciting project with Dr. Sushma Reddy, that is the research director of the cardiovascular unit, looking at specifically these congenital heart defects, neonates that come from our program, and trying to understand better the maternal, the metabolic effects. I have a few things more to share, but I really don't, I want to just convey the message. There's a lot of things going on. Please join us. Something that is growing in the system, and I'm very, very excited, is partnering with the PAC program with Dr. Tyson, and with the adult congenital heart program with Dr. Rums, to see if we can start planning teen pregnancy in these congenital heart defects babies, future mothers. And I want to leave you with this. This is really why we do this, why what we do matters. I wanted to leave you with a piece that the hospital put in the website, and I was very happy to be part of. Kelly on the right had these 2 babies under our supervision. The first time we met her, she was pregnant after an IVF because she couldn't get pregnant, and she was found to have severe aortic stenosis. Here to say that pregnancy took up many years of us trying to get her to deliver safely. She did, and she went ahead to get her valve replaced, also by Stanford. And what was more fun, she came back for second. Ethan got Victoria, little sister, and the patient, from saying that she was tired and dizzy and nauseated and couldn't even climb a stair, now she's absolutely a new person, amazing. She can do yoga, she can do exercise, and be a mother. So I just want to let you know that's why we do this. Thank you so much. And any questions, please?
Thank you so much, Katherine, and thank you, Norma, Lisa, and Lysandra, for your wonderful presentations. Katherine, you've done such an amazing